Hello, my name is Dr. Erik McLaughlin, and I serve as Chief Medical Officer for AB Med Healthcare Solutions. I'm an MD MPH with training in family and emergency medicine and a master's degree in public health. So today we're going to talk a little bit about monoclonal antibodies and COVID-19. This is a little bit of an initial slide just to kind of frame what we know about COVID. This is Arizona specific data. You're going to see up there at the top of 827,000 current cases and 16,328 deaths, unfortunately. This is dated March 8th from the New York Times data. We also know that SARS-CoV-2 is the virus that causes COVID-19, and this is acquired by the inhalation of respiratory droplets or secondary transfer of virus material on your hands when you touch a surface and then rub your nose or your eyes. And it's important to look at what we're using for current treatments for COVID-19, plus or minus steroids, breathing treatments, anticoagulation medications, an antiviral medicine called remdesivir, and then supportive oxygen up to the point of intubation and a ventilator to breathe mechanically for the patient. That's it. Don't have too much else. Everything else we have regarding COVID centers around prevention, vaccines, masking, physical distancing, hand washing. Those are all things to prevent COVID. Treating it is a different matter, and that's why I really am excited to explore monoclonal antibodies a little bit with you today. So what are they? First, let's take a step back and let's look at what just an antibody is. An antibody is something that your body naturally produces to fight infections, whether it be bacterial or fungal or viral. Now, monoclonal antibodies are developed in a lab with the help from a person who has already previously had COVID-19 and cleared it. They were sick and then they got better. So monoclonal antibodies are developed in a lab, and they augment our current antibodies that we're producing to help fight a disease, in this case a virus, SARS-CoV-2. So you can see down here, without antibodies, that virus uses those little spiky proteins to penetrate into the lining of a cell and then start spreading the infection. However, with antibodies, these effectively block that spike protein that prohibits the cell then from being infected by the virus particle. I like to think of that spike protein as like the key unlocking a door into our cell. So that spike protein's on the surface of the COVID virus, SARS-CoV-2. If you block that protein, that spike protein, it can't penetrate into our cells and we don't have infection. So let's talk about B cells for a little bit. B cells are taken from a patient that has already had and recovered from COVID. B cells are very important. We're going to learn a little bit more about those here in a minute. But B cells help produce our antibodies. And B cells, once they get infected, activate and then begin replicating, producing these antibodies that can then help prevent that virus from getting into our cells, or help some special types of hunter-killer cells destroy that virus particle. So what we do is we take those B cells from the blood of a patient who's already recovered from COVID. We take the genetic material out of those B cells, and then that genetic material is used to make copies of that same monoclonal antibody that was previously successful for that other patient in their battle against COVID. Currently, monoclonal antibodies are being used to treat a host of other scary and kind of bad viruses like HIV, influenza, RSV, which is a respiratory syncytial virus, MERS-CoV-2, which is a scary one from the Middle East and similar to SARS-CoV-2, Ebola, and Zika. So those are some scary viruses that are already benefiting from the use of monoclonal antibodies. There's two main manufacturers right now on the market. One is an Eli Lilly offering bamlanivimab, and then Regeneron also produces a 2-drug cocktail, or a 2-type cocktail, that is commonly given together. So how do they work? In medicine, we always talk about the mechanism of action. How does something work? Monoclonal antibodies target the spike protein of that SARS-CoV-2 virus. The spike protein is how the virus enters the cell. So again, like a lock and a key in a door, if you're blocking that spike protein on the virus has no ability to enter into our cells. Both the Eli Lilly and the Regeneron offering utilize 2 antibodies, in fact, that target that spike protein. It's what makes them so efficient, and we'll look at that here in a little bit. So, do they work? So, the concept of monoclonal antibodies was granted an emergency use authorization, EUA, from the Food and Drug Administration, FDA, in November of 2020. That was based on 2 studies. In February 2021, some additional EUAs were issued after seeing success in a number of important clinical trials. And the one I'd like to draw attention to is the BLAZE-1 clinical trial. They took 1,035 ambulatory patients. These are patients in the community, not hospitalized patients. These patients had mild to moderate COVID sickness, but were at risk for progressing to a severe illness. We'll talk about some of those characteristics here in a minute. So of those 1,035 patients, 518 received monoclonal antibodies and 517 received placebo, or sugar water. In the monoclonal antibody arm, only 2% of those patients required hospitalization or died. In the placebo arm, 7% required hospitalization or died. So when we take our public health statistical knowledge and do some calculations, we see that that's about a 70% risk reduction in hospitalization or death in the patients who were treated with monoclonal antibodies. That's really what we're out to prevent, is death and serious illness requiring hospitalization. So how do you take monoclonal antibodies? Well, they're given intravenously. It's a 250 milliliter bag, about 1/4 of a liter, and it's given through an intravenous catheter, put into your vein, just like you were going to get an IV fluid drip, and you have that 250 milliliters of monoclonal antibodies flow into your body. This is, again, done as an outpatient, so you book your appointment, you go in, you get your treatment, and then an hour or 2 later, you leave. Pretty simple, and that's exactly what it was made to be done for. So how do we make these monoclonal antibodies? We take blood from a patient who was previously infected and recovered from COVID-19. We then take those B cells out of the blood that are targeting specific antibodies against SARS-CoV-2 spike protein. We use bait molecules. This reminds me of when I was a kid growing up in the desert in Arizona, and I used to take a magnet from the refrigerator and I'd throw it into the bottom of a river, a sandy, dried out river. And when I pick it up, it would be coated with iron filings. We use that same concept, but we do it chemotactically, meaning we use chemical modulators to attract the B cells that we want, and then we take them out of the blood, getting rid of the rest of the blood products we're not interested in, like red blood cells, other white blood cells, plasma, things like that. And then we take the DNA out of those antibodies from the B cells, and we use them and replicate them, and then they're put into other cells to help augment or mass produce these antibodies. So how do vaccines and monoclonal antibodies work? Because they're kind of different. You're going to see right here, vaccines help the body recognize foreign pathogens by creating antibodies. So when you have a foreign invader like SARS-CoV-2 enter your body, that's going to rev your immune system up and get it ready to fight. You're going to have T cells activate and help B cells, which are then going to make antibodies. You also have cytotoxic cells that directly destroy the virus, like macrophages. So monoclonal antibodies work down here, where we actually are augmenting the body's existing creation of antibodies to fight SARS-CoV-2. This works twofold. This blocks that virus from entering into our healthy living cells, and it also tags the virus cells for destruction by macrophages. That's very important to recognize those differences, that it both prevents and attacks the virus. And that's a wonderful thing. So who's a good candidate for this? Who benefits? The Food and Drug Administration's Emergency Use Authorization, EUA, defines good candidates for this as high-risk patients with a risk for progressing to a more severe disease or eventual potentially death. These are patients with a BMI, a body mass index, at 35 or above, patients with chronic kidney disease, diabetes, immunosuppressive disease like HIV or frank AIDS, or individuals who are receiving immunosuppressive treatment. These are doctors giving them medicine to dampen their immune system. These are patients who may have had an organ transplant, or patients with rheumatoid arthritis or another disease that we use immunomodulators to help combat that disease. Patients aged 65 and older are good candidates for this, and patients aged 55 or older with comorbidities like cardiovascular disease, hypertension, or lung disease like COPD, chronic obstructive pulmonary disease. Also, for the younger patients, ages 12 to 17, a BMI above the 85th percentile, or a chronic disease such as sickle cell or heart disease, or neurodevelopmental disorders such as cerebral palsy, or those patients who may be dependent on medical technology such as a tracheostomy or implanted feeding tube, or patients with chronic lung disease. So those are really our target patient population that we want to get this monoclonal antibody treatment into quickly. And we're going to talk about why we need to do it quickly here. So let's talk about the timeline on this. It's important that your monoclonal antibody treatment has to be given within 10 days of symptom onset. And that can be a challenge. So let's look at a sample timeline of a patient who wakes up Monday morning with symptoms of COVID. Suspicion for it: sore throat, runny nose, fever, cough, maybe loss of smell or taste. And the next step for them is to get their SARS-CoV-2 COVID test. That can take a day or so. And then you have sometimes a day or two to wait for your test results. Well, once you receive those test results, if you're COVID positive, you book an appointment with your local doctor or your local healthcare provider or facility like a hospital, and you begin to get your monoclonal antibody treatment. Now, the concern with this is, again, we only have 10 days to go from onset of symptoms to get your test completed, get your test resulted, and then book that appointment to get the treatment. So this is a challenge. This is why it's important to not delay. If you're one of those patients that would benefit from monoclonal antibody therapy and has a risk of SARS-CoV-2 progressing to a very serious disease, it's important to not delay that diagnosis of COVID and not delay booking your appointment to receive monoclonal antibody treatment. This is a list of my references for the public health geeks out there like myself who want to read a little bit further. And thank you very much for the time, and I look forward to answering any questions you may have.